Welcome to Workshop 17, Extrapulmonary Manifestations and Mechanisms. Thanks everybody for getting up early to come join us. I'm Catherine Cutney. I'm a pediatric endocrinologist. My co-moderator is Agnes Swiatek-Urban, a pediatric nephrologist. And as you can observe, neither one of us is a pulmonologist, fitting with the theme of this workshop. We are excited to bring you 5 really fascinating talks spanning the whole span of the body, only stopping at the lungs when clinically relevant. We're going to start at the brain and move our way all the way down to the gastrointestinal system, starting with 2 talks about the impact of ETI therapy on brain development, and then moving to the pancreas to look closer at mechanisms of CF-related diabetes. And then we'll move over to the kidney, looking at how CFTR function in the kidney can impact the development of kidney disease in people with CF, and then ending in the gut, looking at leaky gut and dysbiosis in people with CF. So we're going to have about 15 minutes for each presenter, and then we'll turn off those mics for about 5 minutes for people to come up and ask questions. You can also ask questions through the app if you prefer to do it that way, though we love it if you come up and ask questions at the mic. And then at the end, if there's time, we'll finish off with a panel discussion. So we'll go ahead and have Agnes introduce our first speaker.
So our first talk will be by Paul Littman from Case Western University, and he will talk about the neurological outcomes in utero and exposure to ETI.
I'm good. Yeah, I got it. Oh, you got it? Okay, thanks. Well, hello. Thank you for having me. I'm really excited to get a chance to talk about some of the outcomes we've been measuring following ETI treatment in pregnant mice and their offspring. My only disclosure is I'm saving some of the brain development stuff to the end of this talk, so I apologize, you have to stay. But in general, highly effective modulator therapy has changed the landscape for pregnancy in CF. Historically, around a third of women with CF experience infertility or some form of subfertility disease. But modulator therapy, and we're going to be focusing on ETIs, elexacaftor, tezacaftor, and ivacaftor, have dramatically improved fertility rates. And as a result, pregnancies in women with CF have increased in recent years. And you can see from this national cohort study on the right, graphing the number of pregnancies in women exposed to modulators in blue versus unexposed, the number of pregnancies has basically doubled in the last couple of years. And because of the benefits for the mother's health, ETI is usually continued throughout the course of pregnancy, even though at this point we don't necessarily know what ETI exposure might be doing to the developing infant. That said, we do know a couple things. There's some really cool pros of in utero treatment with ETI, and we heard some of these at the plenary yesterday. But for the rest of this talk, I'm going to divide this up into kind of for the mom and for the offspring. For the mom, ETI treatment, it's pretty straightforward. Pregnancy without modulator therapy is, one, very difficult. Modulator therapy results in superior pregnancy outcomes, preservation of FEV1 as opposed to an actual decline without modulators. But for the developing offspring, it's where it gets kind of cool. There's been some case studies recently of meconium ileus being resolved, and you can see some. This is pictures from one of these case studies. The image on the left there shows a fluid-filled dilated bowel that's often associated and indicative of meconium ileus. At around 28 weeks, they started the non-CF mother with ETI. And by 36 weeks, the dilated bowel, fluid-filled bowel had completely resolved. The infant was born and passed meconium and first couple normal stools. There's also some neat work in the ferret model. This is from Dr. Englehart's lab a couple years ago, showing the correction of the vas deferens in male ferrets. So their images here kind of show a wild-type ferret with a normal vas, a G551D knockout mouse showing the absence of the vas deferens, and just in the presence of ivacaftor alone, they see the development of the vas deferens again. And this stays even after they remove ivacaftor from the ferret model, so there seems to be some developmental permanence to this. So this is all really cool, but I think there are a couple considerations that we need to take into account. One, what are the impacts of ETI on the mom's health? So anxiety and depression have been widely reported as a side effect of ETIs at this point. And this could be particularly troublesome as it could exacerbate the kind of extreme emotional changes that a mom could experience postpartum. Another thing to consider is pregnancy is really challenging on the liver in general, and ETIs have been shown to have some hepatotoxicity. So monitoring liver health, liver function is also very important. For the developing infant in this case, the one thing to keep in mind is the majority of infants that are born don't need modulator therapy. So this image on the right here are a couple examples of where an infant could be exposed to modulator therapy. The one on the left is a case where a female with CF has a fetus with CF. That said, this is a really rare case. The one on the right, another example, the female, it's a CF carrier giving birth to a fetus with CF. This is kind of similar to the meconium example that I said earlier, but still fairly rare in general. The most common is this one in the middle, a female with CF giving birth to a CF carrier. And this carrier may or may not have any benefit whatsoever to modulator therapy. The other thing to keep in mind is the infants that could potentially benefit may not be able to properly process ETIs in general. They're still developing, they have developing organ systems, developing livers. We don't necessarily know that they can even process the straight doses that the mother's receiving. So how do we go about addressing these kind of concerns? We're going to use a mouse model. And in particular, we're going to be using a mouse model that has a human copy of the gene with the F508del mutation. So this should respond to modulator therapy. When we breed these, we're going to end up with all three genotypes of offsprings that we're interested in are wild-type pups, heterozygous pups, and CF F508del, humanized F508del CF pups. We are going to begin daily ETI treatment when the dam is visibly pregnant, and this tends to correspond to somewhere around the second to third trimester in humans. And then we are going to, for the mom, we're going to have two groups. We're going to look at the mom immediately postpartum, and then a separate group where we take through weaning, and we're going to assess things like anxiety and depression, and we are assessing liver health. And then for the pups, again, we're going to have kind of two groups. We're going to have a group of neonates and then a group that we age to 3 weeks just post-weaning. One, we're going to verify the presence of ETI at all, that it's making it to the pups. Two, we're going to assess changes in lung development and changes in brain development. So for the moms, as you can imagine, measuring anxiety and depression in a mouse is actually kind of difficult. I can't just ask how they're feeling any given day. So we rely on some behavioral analyses. The first one I'm going to talk about is something called the open field analysis. And this is basically we take the mom and we drop her in a big box. And the box has 3 different regions, an outer, a middle, and an inner. The more time the mom spends moving towards those middle parts is kind of a sign of bravery and less anxiety, and the more time she spends running around the outside and not really venturing is a sign of anxiety. So our first set of data here is immediately postpartum. So this is after 10 days of treatment with ETI in the mom. And we don't really see a huge difference in our treated moms in gray compared to our control in the amount of time they spend in each zone, the outer, the middle, and the inner. But when we look again post-weaning, so immediately post-weaning, about 30 days of continuous ETI treatment, we start to see some significant changes happen here. Our treated mom in gray is now spending significantly more time in the outer zone and significantly less time in the inner zone. So she is showing that she's a bit anxious. So we're seeing an increase of anxiety here. And we wanted to see if we could test this again, just with something with a little more resolution. So we did another analysis called the elevated plus maze. And this is basically what it sounds like. It's a maze in the shape of a plus that's elevated about 3 feet off the ground. It has 2 arms that are open, so the mouse can walk out and peer over the side, and then 2 arms that are enclosed. And the more time spent in the outer, the open arms, kind of the less anxious, and in the enclosed would be more anxious. So again, we measured immediately postpartum with 10 days of ETI treatment, and already we start to see some trends here. So our treated mom in the gray spends less time in that open arm and a little bit more time in the enclosed arm. And just like last time, after 30 days of ETI treatment, we start to see this really exacerbate. So she is now spending significantly less time in the open arm, not exploring as much and staying in the closed arm. So again, we're pretty confident that we're seeing some anxiety with the long-term treatment of ETI. Depression, we use a very high-tech measurement where it's called tail suspension, where we basically just gently suspend the mouse in the air for a couple minutes by their tail. And a mouse has a normal kind of escape behavior, so they try to climb and get out, and then eventually they just stop and say, this is my life now. And that's kind of what we're measuring, is the, this is my life now time of immobility. So immediately postpartum, about 10 days after ETI treatment, we already see that the treated mom spends more time inactive, more time immobile, so less time trying to escape. And this is also, again, just exacerbated at 30 days of ETI treatment. So taken together, we are seeing increased anxiety and depression in the moms, both immediately postpartum and throughout a long-term treatment. And I also mentioned that we wanted to take a brief look at liver health, and that's basically what this is, a very cursory look for now. But we wanted to look at liver metabolites in general, and to do this, we looked at the amino acid levels in a panel on the x-axis down here. Oh, I'm sorry. Oh, okay, thank you. So we measured amino acid levels in the liver of pregnant mice just shortly after birth. And I'm not going to go into this a lot, but there's kind of two take-home points here. One, all of the amino acids in this metabolite panel are slightly to significantly elevated here. The second is a couple of these that are very elevated. Serine and taurine are often elevated in the case of mitochondrial shock or liver stress in general. So we're not necessarily measuring liver toxicity, we're just sort of measuring liver function as a whole. But we are seeing some early signs of just general liver stress with constant ETI treatment, just postpartum. So what about our pups then? So the first thing that we did is we used mass spec to fingerprint each of the individual components of ETI to see if we can actually find these. So lexicaftor, tezacaftor, and ivacaftor here. And this allows us to trace it in plasma and tissue of our pups. And this is an example of the brain, the lung, and the liver in our day 21, just post-weaning pups. So this means they're only getting ETI through mother's breast milk. She's being exposed, the pups are just getting it through breast milk, and we're still able to trace all three of these in brain, lung, liver. So that's really cool. So let's follow where it's going and take a look at the lung first. So our group and some other groups in the past have shown that there is a difference between CF and non-CF mouse lungs in pulmonary architecture, especially in the distal air spaces. So we thought it'd be kind of neat to see if the ETI treatment would have any effect during development on that. So we took a look at the lungs of our just born neonates, of our non-CF and our CF, both treated and untreated. And to see if there's a difference, we measured the alveolar area. So basically, we went through and by hand measured every single alveolar space and then determined the area of each one of those across multiple mice and multiple tissue. And all of that data is nicely summarized here. So the thing to keep in mind here, the non-CF controls have the largest alveolar circumference that we saw. And area that we saw. The non-CF mice, when treated with ETI, have a significant reduction in alveolar area. In fact, it reduces it so low that it starts to look like our CF mice. And then again, with our CF mice, if we treat them with ETIs, we see another reduction in alveolar size in these. So not only is ETI not necessarily correcting the CF phenotype back towards wild type, it seems like it's making them all a little bit worse. So that's kind of the lung story. What about the brain I mentioned earlier? So we started with a really cursory look, and this is a pretty simple measurement here. This is just taking histology on our control mice on the left and our ETIs on the right, and measuring the diameter of some of the kind of major regions in the brain from lateral to medial. And the first thing that we noticed is in our ETIs on the right, we see an increase in diameter of a couple regions, the primary somatosensory cortex, and again in the corpus callosum. And we thought this was kind of neat. It could be it's a very simple measurement. It could be a figment of the histology or it's something like that. So we wanted to test this again. So we aged our mice up to the 21-day just post-weaning, and we subjected them to the MRI to see if we could see a difference in the overall volume of the brain. And when we did, we actually saw that this kind of recapitulates what we saw in the histology. There is a significant brain enlargement in our pups exposed to ETIs. You can see that in both the picture on the right and then the gray bar on the bottom. So where are we at this point then? For the moms, ETI treatment during pregnancy does seem to definitely increase anxiety and depression in the mice, as verified by our behavioral tests. The liver metabolites, while we're not necessarily showing something like toxicity or damage, we are showing some liver stress, and liver metabolites are elevated at birth following ETI treatment. And then for our pups, ETI is detected in all tissues that we looked at, the lung, the liver, the brain. It's transferred from the mom through breast milk. We see it even more early in our neonates at day 0 in plasma. So we're one, effectively able to trace it, and 2, trace it in all the tissues that we were looking at. 2, ETI exposure seems to significantly reduce alveolar circumference and area in our CF and non-CF pups. And I think that's kind of the interesting part that's in our non-CF pups as well. So this could result in impaired gas exchange, pulmonary challenge. We're not sure on all of these, and this is something we're going to be measuring going forward. We're going to have some later cohorts that we're going to be looking at. And lastly, ETI exposure results in notable brain enlargement. And I want to make it really clear, I don't know if these results are even close to clinically relevant or anything like that, but I did want to point out that things in like brain enlargement in general can be associated with seizures, developmental delays. The corpus callosum in general, for instance, is associated risk for autism spectrum disorders, epilepsy. So I think that why there's a lot of really cool stuff that's happening within utero treatment and kind of pushing back that time frame, I think it's safe to say that some caution at least is warranted, especially in these kind of early treatment areas. I'd like to acknowledge the DARA lab and Dr. DARA in particular for being a wonderful mentor. All of our cores that helped, Dr. Hodges with the mice, Dr. Barbado for all of the histology help, our Center for Research Imaging and Dr. Chris Flask for MRIing a day 21 pup brain, which I think is still a medical miracle, and our mass spec core. And I'll take any questions. Thank you.
Yep, go ahead.
Hello, Dr. Schelde from Case Western Reserve University.
Hello. Stop. Really nice talk.
Thank you.
I was thinking, you showed the mass spec data where one of the ETI modulators did not go to the brain, or 2 of them, I think. What if you did the same study and you took that one out? Would you then see the same brain enlargement?
Yeah, so I guess the question, I guess at its root is each individual, do we know exactly which one is responsible for kind of the brain enlargement out of the 3 if we took one out and looked at the others? I don't know. So we've seen some evidence that some of the potentiated, like ivacaftor in general, that would kind of be where I would be leaning towards, as it would actually be the one that's up potentiating something and not necessarily in some of our, especially in the wild types, our CF's already there and it's CFTR is there and it's doing what it's supposed to do. So it doesn't need to be corrected, but the potentiation may be what's causing it. So I'd probably start there if I had to guess, but I'm not sure if it would individually or in combination have the same effect at all. But it's a good question. I think eventually we're going to be looking at so we'll be looking at the metabolites as well, the breakdown of the ETIs in all of these tissues to see if maybe it's because they stay there too long, maybe it's because they're not, maybe it's an individual component. So these are all questions we're going to be looking after kind of seeing these first outcomes.
Really nice talk.
Thank you.
I was wondering if you see increased inflammation in the brain as well, not just the enlargement, but infiltration of immune cells or activation of them.
Yeah. So we haven't looked yet, is the short answer to that. But the outcome is definitely giving us a lot of things that we want to look at. I think inflammation is one of the things that could cause this. So when we think of the enlargement in the brain, there's only so many things that can happen, right? There's not that much in my brain. There's not much going on at all. But there's only neurons, axons, oligodendrocytes, myelin. So it could be inflammation. It could be fluid secretion. It could be increased cellular number. It could be swelling of myelin. So we're chasing a lot of different potential mechanisms for the outcome. But yeah, that's definitely one. Inflammation could be one, especially when we consider that. So like myelin isn't even starting to form yet in these pups. That's kind of a later developmental stage. So just being in the presence of the ETI that we know is now crossing into these areas, acting on an unmyelinated axon, we're not sure what that is doing. So yeah, it's one of the many things we'd like to look at. Thank you.
Carlos Farinha, University of Lisbon, Portugal. Great talk.
Thank you.
So there have been reports that tisagenlecleucel specifically inhibits an enzyme in sphingolipid metabolism, leading to accumulation of dehydrocyramide in the brain, and these may affect myelinformation. So can you comment this probably is compatible with the changes that you have seen?
I couldn't begin to comment on that because I only stood half of the words you said. But no, not because of a language barrier, because I have no idea what I'm doing. But
I'm trying to speak English.
I don't know, and I would maybe if you could hit me up at the poster at 3:50, and maybe we can talk about that, because I'm definitely going to be chasing every outcome we really can on this. So thank you so much. I'm sorry to just say no and tell you to walk away. That's an awful response.
Thank you for your talk. So a quick question. So you treat the animals with ETI for the whole pregnancy?
Yes, so we treat, well, no, not through the whole pregnancy. We treat them as soon as we notice they're visibly pregnant. So this is it's usually about 10 days post-copulation. So it leaves about 10 to 11 days of treatment before birth. Yeah.
Have you checked how early those changes occur, or have you waited until they were born?
No, so for now we were starting with neonates. So I think that's going to be a really good question in time, is trying to actually see, especially in development, because so much can happen so fast, especially in a mouse model, right? We have 21 days, and that's that. Lung development changes that happen early, and they can be kind of permanent. So I think narrowing that down is going to be something that we will eventually look at. We can also maybe try to approach this with like a turn on, turn off model, and see if we see a difference in the, lack and presence thereof, things like that. But we definitely want to look more into temporal training, but we have not gone earlier than neonates.
We do 4 days, so we'll see next week.
Yeah. Of course.
We're going to take
just time for one more question, and then at the end we'll have the panel here. Sorry. So just one more.
I was just curious about the anxiety and depression studies. Have you done this on non-pregnant mice, and have you seen similar results, or is it just the pregnancy that's important?
No, so I haven't personally, but some in our group have established a phenotype between CF and non-CF mice, just not pregnant adult mice, and there is an anxiety and behavior phenotype, but it seems to be exacerbated compared to our controls here that we're looking at for sure, and just in the presence of ETI alone too.
Thank you.
Thanks.
Thank you so much.
Of course, thank you.
And I'm happy to welcome our next speaker, Dr. Veronica Campanucci, to the stage.
Sorry, I'm short, so I had to lower this. Hopefully you can see me. Can you hear me here? Okay. Thank you very much, and thank you for inviting us to present. I'm Veronica Campanucci, Associate Professor from the College of Medicine, University of Saskatchewan. And today I'm going to be talking to you, I'm not going to disclose anything about this study. And today I'm going to be talking about disruption of hippocampal function by ETI therapy. And the work was actually done by my master's students, and Min Vu. Unfortunately, he couldn't come this time. So let's see what we have done. So why are we interested in studying the effect of ETI in the brain? Well, I think after your talk, it's very easy for me. There is information, there are reports showing that there is depression, anxiety, there are new worsening neuropsychiatric symptoms reported. Depression has been reported, attempts of suicide and self-injury in the first year of treatment after ETI started have been reported. So all this has prompted a workshop at the Cystic Fibrosis Foundation, and this. So one of the excerpts of the report is that future studies should focus on understanding the role of CF in the CFTR in the nervous system, and defining ETI impacts in preclinical models and the mechanistic investigations. So that's where we'll come in. We took up this challenge, and we've been studying the effect of ETI in the central nervous system. So our hypothesis is that ETI modulates synaptic activity and plasticity, and thus neurotransmitter responses in the brain. And based on our research on peripheral neurons, we also propose that ETI alters chloride homeostasis in the brain, which is extremely relevant for inhibitory synapses. How we have done this? Well, we have focused on the hippocampus as a model system for central synapses. The reasons why, well, we work on the hippocampus, but the reasons why the hippocampus is good for this. It's a well-defined anatomical area. It has well-characterized circuits. There are specific roles of the hippocampus in learning and memory and depression that we can test on. And on top of all that, there are specific hippocampal-dependent behaviors that if we find effects, then we can go and check them, similar to what we just saw with the previous speaker, so to see if our findings are relevant for any kind of symptomatology. So this is the coronal section of the brain of a mouse, and you can see here the hippocampal area. The circuit that we are exploiting for this research is the Schaffer collateral, is the one that the presynaptic units in the CA3 area to connect synaptically to the CA1 area. I'm not going to repeat this again, so I'm just showing it to you. And of course, this has been extremely studied synapse. We know how it works, and we know that it's a glutamatergic synapse that depends on NMDA and AMPA function. So, the methods on how we do this research, we also use the humanized mice from Case Western. These mice are CFTR mouse knockouts, and they are homozygous for the human version of the gene, and they express either the wild type or the delta FOA. And we use them at two different stages because of the kind of experiments that we perform. So we use adults, and we treat them by IP injections with ETI only 4 days. So that's what I was asking you about, how many days you treat them. And then we remove the brain, we collect the hippocampus, and half of the hippocampus is used for slice recording for electrophysiology, studying that circuit that I just mentioned. And the other half is used for immunoblotting for protein analysis. For a specific patch clamp electrophysiology of neurotransmitter receptors, we avoid the slices because we use a different form of patch clamp that is very hard to do in slices. So for that, we prefer to do it in culture neurons. So unfortunately, the hippocampus cannot be cultured from adults, so we had to use neonates at the same genotypes. We collect the hippocampus, we generate primary cultures, and in this case, the cultures are treated for 48 hours with ETI in vitro or with control solutions. And then we can record from single cells and study the neurotransmitter receptors. Specifically with that, what I'm going to show here is AMPA, NMDA, and GABA. So what kind of results we got? So this first part is on slice recording, and this work was done with collaboration with Dr. Borer's lab in my department. His PhD student, Alina Trofimova, and my student at that time, Min Vu. And they were the ones collecting all the slice information. So we found two main things. So I'm gonna summarize it first, and then I show you the details. So the first thing that we found is that there is a phenotype in the CF hippocampus. So we found some deficits in the CF synaptic activity, and the important thing was that ETI was able to restore that function. So these are the kind of records that we collected. And if you look at on the left first, what you see is the quantification of the amplitude of the excitatory postsynaptic potentials. And if you look at this bar first, this is the bar from the CF control, so not treated with ETI. And you can see that the amplitude of the PSPs is significantly smaller with respect to the control's wild types. If we treat these animals with ETI, now that is restored, so it goes back to normal levels. The other thing that we did with these recordings was we analyzed the input-output ratio. This is a measure of the efficiency of the circuit to grab a stimulus and convert it into an EPSP, into an excitatory response. So what we can see here is that, again, the CF control, even though it's a trend at this point, we are collecting more data for before publication, even though it is a trend, you can see that is much smaller than the wild-type control. And again, ETI restores that. In this case, overcompensates for that effect. So it's going in the right direction. And on the right, what we have is the analysis of the threshold. So this will tell you what is the minimum amount of stimulus you need to apply to the hippocampus to fire that particular circuit. And what we can see here again is that the amount of stimulation that you require in the CF control is significantly higher when you compare with the wild-type control. And again, ETI seems to restore that to bring it to normal levels. So this is showing that ETI is actually doing something good. We have a phenotype in the CF hippocampus, and ETI seems to be resolving it. Then we went into synaptic plasticity because the hippocampus has this ability to be that you can potentiate it. And potentiation of the hippocampus is important because it is related to many conditions. Depression is one of them. And so impairment in hippocampal synaptoplasticity has been linked to different cases of depression and anxiety. So what we have here is the recordings, and what we saw is that ETI can enhance synaptic plasticity at the hippocampus. So here is the actual induction of synaptic plasticity or long-term potentiation. This is the amplitude, the relative amplitude of the synaptic responses. This is before the stimulation. This is stimulation that causes the potentiation, which is all this result here. And we analyzed it at 2 points, early LTP or long-term potentiation and late LTP. And in early LTP, we see that the same trend that we observed before, but now we also include in the wild type. So what we saw is that the CF control, again, it has a significant reduction on the LTP, and that is restored by ETI. But then we also saw the same trend on the wild type. This is problematic because LTP and potentiation and synaptoplasticity is all about balance. So, but imbalance both ways is an issue. So we'll see what this might mean. And in late TP, we actually don't have any effects on the CF. We only see it in the wild type. So again, this is calling imbalance in the hippocampus. So the summary at this point from the brain slices is that we found a synaptic deficiency in the CF mice, which was restored by ETI. And then when we look into synaptoplasticity, we found that ETI actually have effects in both, in the wild type and also in the CF. So next we move into studying what kind of mechanisms might be underlying that effect. So we had to go and look into the neurotransmitter receptors. So we look at AMPA, NMDA, and GABA. And what we found is that ETI actually can improve deficiencies that we observe in GABA. So if you remember what I told you that there were deficiencies in the hippocampus, in the brain slices, we found that if we look at the amplitude of the AMPA evoked currents, AMPA is the neurotransmitter receptor that initiates activity in the hippocampus, then recruits NMDA. So AMPA is the first one, is the gate, is the one that starts it all. So what we see is that in the CF control group, again, there is a significant reduction in the AMPA evoked currents, and that effect is actually resolved or improved, not totally resolved, but improved by the ETI treatment. This is in vitro. And when we go and look at the NMDA receptors, what we found is no effect. There is no phenotype related to NMDA receptors, and ETI doesn't seem to be doing anything to NMDA. So this is kind of supporting, not confirming because it's a different kind of experiment, but it's supporting the idea that early stage that we saw in synaptoplasticity is actually AMPA mediated, because we can see that AMPA is initiating it. So next we look into GABA. And what we found is that GABA is a chloride channel, and chloride homeostasis is also altered by ETI. This is kind of a repetition of what we observe in the peripheral nervous system, and that's what we're very interested in studying, because chloride levels in the central nervous system are extremely important for inhibitory synapses, and if you don't have that, you end up with seizure activity. So what we did is we used GABA as the measurement, but what we were looking for was actually the nurse equilibrium potential, which is an indication of how much chloride is inside the cell. So if you take a look here, what you can see is in black is control, and in blue is the ETI. And what happens in the ETI treated cultures is that the nurse equilibrium potential is shifted to the right, sorry, in the middle, is shifted to the right. And which means that chloride homeostasis is interrupted. This means that there is much more chloride inside the cells than it should be. And the interesting thing is that we only see this in the wild types. We do not see any of this in the CF. So this, again, is showing that something is happening to the wild types that shouldn't be happening. So the conclusions or the summary at this point is that ETI enhances AMPA occurrence in neurons from CF mice and alter chloride homeostasis in neurons from wild-type mice. And this last part is what we think that might have an issue with inhibitory synapses in the brain, and this might be related to what we saw in the wild-type's synaptoplasticity. Synaptoplasticity is extremely sensitive to chloride levels, and it can actually be potentiated if you have less GABA activity. So this could be a reason why we observe that in the LTP recordings. So next, and lastly, what we did is look at, grab the other part of the hippocampus and look at the pattern of proteins that are involved in this kind of mechanisms that I just described, and see whether, how how are the levels and how the phosphorylation stage of these proteins. And what we observe first here is KCC2 and NKCC1. The reason why we consider these two first is because these are the two transporters that in central nervous system are responsible for setting the levels of chloride in the neurons. So both are expressed, and the level that they are expressed and active determines how much chloride is inside the cell. They have opposing actions. So KCC2 is a chloride extruder, and NKCC1 loads the cell with chlorides. So depending on how much they work, you end up with different levels of intracellular chloride. What we see here is that when we look at KCC2, which is the one that is highly expressed in central neurons, we see first an increase, but that increase also is, we see it in the phosphorylated version of KCC2 at threonine 107, that actually this phosphorylation reduces the activity of the KCC2 transporter. So this seems to be linked with the shift in the chloride homeostasis that we described before. When we look at NKCC1, there is no effect. There is no changes in the genotypes, and there is no changes by the treatment. And next we look at AMPA receptors, and specifically we look at the GLUA1 subunit, because the GLUA1 subunit is the one that is mostly modulated, phosphorylated, is the one that is responsible for the membrane insertion of the channels and the conductance of the channel. So when we look at this subunit, what we found out is that the GLUA1 subunit is phosphorylated at serine 031 in both groups, in the wild type and the CF treated with ETI, and this means that this phosphorylation enhances the conductance of this channel, so there is more AMPA current, and this could be correlated with effects that we saw in synaptoplasticity in both genotypes. So protein analysis revealed changes that support our electrophysiological findings, and these are so far the conclusions that we have from this study. This is part of the study. Unfortunately, I don't have the time to show it all, but I'm welcome to chat more if you come to our poster. So ETI affected hippocampal function in both wild types and CF mice. And in some cases, ETI was able to restore deficiencies, and in some other cases was able to cause imbalances, such as the one what we observed in the case of KC2 and chloride homeostasis, and also when we saw increased activity in plasticity in the wild type. So what we'll be doing next, and I'm just about to finish. So the first part, you guys are doing it, so we leave it to you. The next, for this, because the hippocampus is so good and so robust for behavioral testing, for us, the next thing will be to go into behavior. Requires a lot of mice. So shout out to Case Western. So we'll see how we do that. But the other thing that we also want to do is to bridge the gap between mice and humans. We are actually working on this, and we are generating human-derived cerebral brain organoid slices. So we are growing organoids from iPSC cells from CF and non-CF donors, and we leave them for 3 months. We haven't get there yet, but we're going to leave them for 3 months. Then we can do slices, and they have a very complex morphology, and they have circuitry that we can actually test in the similar way that we tested the hippocampus, and we can treat them with ETI and see if we have similar effects. So this is a thank you to all the lab trainees, Min Wu specifically, because he was the main driver in this study. My collaborators, Juan Janowski and Julian Tam. Juan Janowski is here with us, with his students. Julian Tam is back in Canada, and all the agencies that are supporting our work. So thank you very much, and I will enjoy your questions.
Great talk. So there's been some reports that ETI can affect potassium channels. Are you guys thinking that too?
Yeah. So that report on the BK channel in the hippocampus, they treat it acutely. And we try it. So there are two ways to treat when you neurons with ETI in vitro. You can do it acutely, just expose to them and measure, or you can treat them and incubate them. So we did both, and we find different results in acutely and incubation. We did see the effect on the potassium channels as well, and but there is an effect, but we haven't seen the effect in the incubated one. So we don't know if it goes away or we need to treat it for longer. Okay.
Last question.
That was a great talk.
Thank you
so much. I'm Danica from CASE. I was wondering, you show a consistent trend of decreased LTP and hippocampal responsivity in the CF mice that are not treated. I was just hoping that maybe at some point you had exposed the wild types to a CFTR inhibitor, and if that recapitulates what you see in the CF mouse model. Have you done that?
We haven't, but it is in the works. Yeah, we have.
Thank you.
I think she stole my question. My question was basically, can you recapitulate these data in CFTR knockout mice? Because I'm curious if it has to do with CFTR function or if it's something to do with an off-target with ETI.
We know from knockout pigs that it's not just a CF issue in neurons. The pathways that are related to the wing, all those pathways related to CFTR function, are also down. So, and we are looking into if those pathways are recovered or not, and so far we don't see them recover. So it is like a bigger picture when we are grabbing the neuron more than just something at the membrane with ETI. So, yeah, no, we haven't done the inhibitor. We should, yeah.
Okay, great.
Thank you very much.
Thank you. And the next talk is going to be presented by Camilla Margarelli.
Thank you, and thank you for inviting me to present our work. Thank you all for being here so early in the morning. I have a disclosure for this talk. We're funded by Vertex through the CF Research Innovation Award. So today I'm going to present some data from a study that we started about a year and a half ago, and take a 90-degree turn from the brain and go a little bit more into the immune system. So we started being interested in CF-related diabetes because we still don't know how the immune system reacts in this subset of patients. And with our aging population, the incidence of CFRD is thought to going to increase dramatically. Patients that have CFRD actually experience a much faster decline in lung function that starts between 3 to 5 years before they actually get a CFRD diagnosis. And we still don't know the mechanism behind this. There had been proposed mechanism of microangiopathy, chronic inflammation in the lung, collagen glycosylation that increases stiffness, but we still don't know the actual cause of it. So the first thing that we did, we took sputum from our patient cohort, and we analyzed whether there was increased inflammation by measuring proteases in the supernatant. So NE is neutrophil elastase, is a protease that is released by the neutrophil that migrate into the lung. And as you can see, it's increased in patients with CFRD. And MMP9 is another protease that is secreted also by the neutrophils and was as well increased in this population. So this could lead to exposures of new epitopes in the lung. Because of these proteases can cleave the matrix, it can expose certain epitopes that were previously hidden. So I'm going to give a little bit of an overview of the T cells. So for those of you that are not immunologists, there are many different flavors of CD4 T cells. This is a subset of cells that is involved in many different responses. And depending on the subtypes that they have, they secrete different cytokines to perform different functions. In CF, what we see is that our immune system is skewed a little bit towards what is called a Th1 response. In a subset of patients, we see now with Dan Cook's work that there are some subset that actually develop more of a Th2 response, but we still don't understand how this is regulated. In the lung itself, there is a predominance of Th17s. However, these cells reside in the parenchyma, which is very hard to sample in humans. And there is another subset that is called T regulatory cells. So these cells are the ones that are going to be responsible to maintain tolerance in the body. They are the ones that are dampening the immune response so it doesn't attack your own cells. And there has been a ton of work that I'm not going to go into details throughout the years in the immunology world, not in CF, on how the metabolism of these cells helps shape their function and how they react. So as you can see, when you have a Th1, Th2, or Th17, these cells rely more on aerobic glycolysis versus the T regulatory cells rely more on fatty acid oxidation. And so this brings me to our overarching hypothesis, is that in the CFRD patients, we see an increase in glucose. And this can work at the same time on two different arms. It can increase airway inflammation on our innate immune system, promoting release of proteases that can expose new epitopes. And at the same time can promote a shift in the T cell responses. And while airway inflammation exposes new epitope, now we have a hyperactivated T cell response that can promote autoimmunity and can start to recognize epitopes that are self, that shouldn't be recognized. And this leads to a faster decline in lung function. So the first thing that we did, and this is 60 patients in one figure. So it took a little bit of time collecting these samples just to get this one image. But we sampled 30 patients that have CF and no CFRD, and 30 patients that actually have CFRD. And then we phenotyped their CD4 T cells by flow cytometry. So this allows us to understand different protein expressions on their surface and their activation status. And as you can see, there are some clusters of cells by unsupervised clustering that are present in CF and are not present in CFRD and vice versa. So if we dive into the actual clusters and we pull apart these two groups, you can appreciate these differences a little bit better. And so we went on and identified clusters that are differentially expressed between these two groups, or differentially present, I would say, and then basically analyze the type of activation that these T cells actually have. So for those of you that are not immunologists, so 2-MBDG is a fluorescent analog for glucose. So if cells are activated and uptake glucose, they become fluorescent. CD27 and CD28 are also activation markers, as well as CD69. CD95 is very low on T cells that are not activated, and it starts to get higher when there is activation. CTLA4, in contrast, is an inhibitory marker, so it's being exploited a lot in cancer. And CD25 is the IL-2 receptor, so this is highly expressed on these T regulatory cells that are inhibiting autoimmunity. And as you can see, none of the clusters that are different, that are present in CFRD but not in CF, express this CD25. So we think that there is a skew of the immune system with a loss of Tregs. Now, this is surface markers. We're getting back to our samples in the freezer and determining exactly which subset these cells are, because we can do intracellular staining. So that is in the work, and hopefully we can present them next year. So the next thing that we did on the same samples that we collected by flow cytometry, we preserved them for RNA sequencing to better understand their phenotype. So we combined single-cell RNA sequencing with a technique is called Cystic. So this uses basically antibodies that are bound to oligos, and you can sequence them at the same time. And we chose this approach because there is an isoform on the T cells that switches between what is called RA and RO, and that tells you when T cells are actually seeing antigen. So if a T cell doesn't see antigen, it's positive for RA, but if it sees antigen, it switches the isoform to RO. And you cannot detect this by RNA-seq, you need to actually go with an antibody. And then at the same time, we phenotype these cells to see what they're actually recognizing. So through their receptor called T cell receptor or TCR, you can sequence the gene, and then you can determine which proteins they're actually recognizing on a presenting cells. So the first thing that we did, we looked for basically T cells that had experienced antigen, so those that were CD45-RO positive. And as you can see here in our healthy cohort, there were none in the blood, which is perfectly normal. In CF, we start to see 4.8% of the T cells, of the CD4 T cells that actually are experiencing antigens. And that percentage is increased in the CFRD group. And then when we went in and look at those that are actually clonally expanded, it means that are seeing antigen, but then we see that there are multiple T cells with the same TCR. That means that they're actively seeing an antigen, they are responding to it. We don't see any of those in the CF group, but we see about 18% of the CFRD ones that are seeing antigens and they're expanding, so it means they're responding to it. And then of these 18%, most of it were effector memory cells, which means that these cells are the ones that are going to go into the tissue and respond to those antigens. So how does this relate to actual autoimmunity? So we know that these T cells are responding to antigen. We have identified a few potential proteins of interest. Most of those are viral, and that's the bias because of how the databases are built. However, we're looking for molecular mimicry to see whether there are human proteins that are representing the same peptides. And you need a CD4 T cell help for B cells to produce antibodies. And to produce antibodies that they have high affinity for their antigen. So we looked also at the B cell responses in a subset of these patients. And as you can see, even though it's not significant, there is a slight increase in a cytokine called BAFF, which is basically needed for B cell fitness. And if we look at the antibodies that are right now in the plasma, and we use them against the epithelial cells, we can see that the CFRD group actually has an increased amount of antibodies that recognize proteins expressed in lung epithelial cells. And not only that, the amount of these antibodies actually negatively correlated with FEV1. So right now we are running 2D gels on these CF airway epithelial cells to see whether we can actually pinpoint the proteins that these antibodies are recognizing and whether that matches what we see in our T cell responses. And if we do, we have a bingo. So as far as conclusion and future direction, we do see a unique CD4 T cell activation in CFRD that is actually linked to an ongoing exposure to antigens that leads to their activation and clonal expansion. There is an inverse correlation of autoantibodies against the lung with FEV1. And we're currently exploring exactly which epitope or which proteins are these cells recognizing, and hopefully come up with a therapeutic strategy to prevent this. So with that, I would like to thank my lab. As you can see, we're starting training very early on. I would like to thank all of our patients who are very willing to give us samples all the time, and especially Dr. Garcia, who's critical for us in the clinic, and Dolores here, who has done many, many different late nights processing patient samples. And thank you to our funding. And thank you all for being here. I'll take any questions.
I'm going to start with one question, if you'll humor me. The patients who don't have CFRD, how do you know? I guess like CFRD really is like a spectrum, and probably every patient with CF has an abnormal, with at least pancreatic insufficient CF has an abnormal pancreas. How do you define no CFRD?
So with the modified OGTT testing, so we're not looking at kind of like the gray middle spectrum. We're looking at the two ends. A future grad will be to see whether we can define, a threshold clinically that could determine whether you start to have these autoimmune responses or not.
So they have like frankly normal OGTTs.
Yeah.
Okay, thanks.
Hi, Eddie James from BRI here in Seattle. Really interesting project. I guess first I want to mention we're doing some similar work looking at CF versus CFRD using a 30 plus parameter flow panel. So we should maybe compare notes.
Yes.
Yeah. But I was curious. I do a lot of work in rheumatoid arthritis, which is another human inflammatory disease that has a lot of lung involvement. That disease also has a neutrophil signature. When you have a lot of neutrophilic activity, it activates an enzyme called peptidyl arginine deaminase, which citrullonates proteins, which creates neoepitopes in RA. Have you thought about whether maybe something like Vimentin might be being citrullonated in the lungs in this CFRD scenario? Is that on your radar at all, looking at citrullination as a mechanism?
It could be. We're just starting from the ground up. So yes, definitely. It's also like in the lung itself, it's hard to sample, humans in the parenchyma. We know that neutrophils, besides arginase 1 and besides neutrophil elastase that can actually inhibit T cells responses in the airways, we don't know in the parenchyma whether those interactions are happening and whether we can actually see a more T cell dominated response in the lung parenchyma versus the secretions, right? Elastase can also cleave antibodies, IgGs and IgAs. So that happens in the sputum, has been shown, but we don't know in the lung tissue what's going on. And I think we're going to have to rely on some mouse models to start to address that question. But definitely citrullination, yes. We see auto antibodies against neutrophils as well in this cohort, which has been related to, disease progression as well.
Right. Thanks, well, we should definitely talk.
No problem.
Hi, Ili Betterman from Case Western Group. Very nice talk and very detailed work, obviously, lots of data to go through. I was curious, as you mentioned in the beginning, this potential shift from glucose to fat utilization that would involve more mitochondrial function. Have you looked at any signs of mitochondrial stress, mitochondrial biogenesis? There's plenty of markers that you could explore.
Yeah, so what I haven't shown here is that we did metabolic profiling using the Seahorse platform. At the baseline, we don't see significant differences. However, I want to see when we activate the cells, whether we're going to see differences there. We're also we kept the cells, we're going to stain for mitochondrial, fusion or fission and see how that relates to, T cell function. There's a huge literature body of work that has been done before in other scenarios, but definitely that's part of the panel that we're using to define the subsets of T cells right now. So
yeah,
hopefully next year.
Looking forward to those. Thanks.
Thank you.
Hi, Rebecca Hull-Michaely, University of Alberta. I thought Eddie was going to ask my question, which is why I didn't stand up early. So the other thing that might be different between the CFRD and no diabetes is pancreatic endocrine injury. And there's some evidence in the literature, and again, Eddie might know this better than I do, that there's autoimmune signatures, T cells, that have been described in people with CFRD sort of similar to what we see in type 1 diabetes. And I'm wondering if you have such a lovely data set here that perhaps you could look to see if there are any antigens that have been described in diabetes.
So we have looked, and what the things that we found right now is like 90% is like viral antigens.
Right.
Where I'm waiting for my bioinformatician to get back to me with like the molecular mimicry and with the literature that has been done. That's the task that I gave him before coming to the conference.
Yes.
As far as human proteins right now, we're seeing some proteins that are secreted by the epithelium that binds to the extracellular matrix. I'm not allowed to disclose that yet because it's not fully confirmed.
Yeah.
We want to confirm in an independent analysis before we present it. But definitely, yes, we're looking at the type 1 and also type 2 diabetes literature for inspiration.
Yeah, fantastic. Just also, obviously, there's ductal epithelial injury in the pancreas in CF, and we're just finishing up a single nuclear transcriptomic project, which shows some really interesting differences in the ductal compartment. We don't have enough N to really say diabetes versus no diabetes, but if you have any epithelial targets, we may need to talk also.
Absolutely. I have a poster at 357, so feel free to
I will.
stop by.
Yeah. Okay. Thank you so much.
No problem. Thank you all.
Thank you. And our next speaker is Hayretin Yavaz, presenting absent CFTR function is associated with progressive kidney injury and abnormal mineral metabolism in a CF mouse model. Just this.
Okay. Good morning, everyone. Thank you for having me. So our lab has been working on cystic fibrosis related kidney disease. As people with CF live longer due to modulator therapies, cystic fibrosis related kidney disease is becoming increasingly recognized. However, its underlying mechanisms remain poorly understood because kidney has a broad hemostatic function. Kidney tubules play a central role in maintaining homeostasis. They actively transport metabolites and electrolytes, handle acid-base and water balance, regulate mineral metabolism by transporting calcium, phosphate, and magnesium, as well as various organic compounds and nutrient transport. There are multiple factors related to CF multi-organ disease that could be contributing to CFKD, such as dehydration from sodium and volume losses, acute kidney injury from medication side effects, chronic kidney disease from inflammation, glomerular disease, for example, because of diabetes and liver disease, and kidney stones from abnormal mineral metabolism. We know that CFTR is expressed in kidney tubules, as shown in previous study. So, okay.
You just don't have to lean in as much.
Okay. So we wanted to ask whether the absent CFTR in the kidney also directly contributes to the pathogenesis of CFKD. So it's also known that CFTR plays essential roles in different parts of the nephron. In the proximal tubule, it contributes to endosomal acidification and receptor-mediated endostasis, which are essential for the uptake of low molecular weight proteins. And when CFTR function is absent, this process is impaired and leading to low molecular weight proteinuria. And in the collecting duct, CFTR is involved in bicarbonate secretion. Without functional CFTR, the kidney cannot properly excrete bicarbonate during dehydration. Absent CFTR is associated with kidney fibrosis through beta-catenin activation. Because of the association of the absence of CFTR function and tissue fibrosis, we wanted to examine the effects in the kidney tubules. And we took advantage of the ability to measure injury by examining the transition from columnar epithelium to squamous epithelium in glomerular junction. Glomerulotubular junction is the most sensitive area for the tubular injury that can be detected by a specific stain, which is lotus lectin staining. So we wanted to identify if the absent CFTR function is causing any injury to the kidney tubules. We used a well-characterized and validated CF mouse model expressing G542X, which we'll refer to as knockout, and then control we'll refer to as wild type. We examined 3 age groups, young, aging, and old. In the young group, we did not see any difference in the number of injured GTJ. Over time, when the animals started aging, we saw a progressive increase in the number of injured GTGs in the knockouts compared to wild type. As we were seeing histological changes, we wanted to examine if there is a kidney injury marker specific for the proximal tubule. And we decided to measure urinary KIM1, which is a biomarker for kidney injury. And it's expressed by proximal tubule. As you can see, there is no difference in young model, which is consistent with our histological data. And there's increased KIM1 levels in old knockout group compared to wild type, which is also consistent with our histological data, suggesting that there is a proximal tubule injury in old knockouts. Since we showed that there is injury in the kidney tubule, and we also know that the tubules are responsible for different transport mechanisms related to sodium, potassium chloride, acid base, calcium phosphate, and inorganic or organic compounds, we wanted to study what happens with the different transport mechanisms that are happening in the absence of CFTR. So we performed RNA-seq kidneys from young and aging knockout and wild-type control, and 4 kidneys for each group. As you can see, that the transport mechanism was altered in 4 major categories in young group. The data were analyzed by Venn method, which is a single-cell gene set scoring method. And basically, the darker colors means higher the differences, and the larger circles indicate higher significance. And statistically significant differences are marked by asterisks. And the transport mechanism was also altered in 4 categories in aging group. Now I'm going to show you data for the calcium, phosphate, and magnesium. And I'm going to focus on calcium because little is known about the role of CFTR in the maintenance of calcium. This is a heat map showing the effects of CFTR in young group. Knockout in beige and wild type in blue. Changes in the genes regulating calcium in green, phosphate in red, magnesium in blue. The oranges are the highest expression starting from the proximal to distal tubule. And the dots are major genes that are influencing the 3 metabolites and vitamin D. I'm going to walk you through the reabsorption of calcium in kidney tubules. It's a complex process actually, but these numbers are indicating the percentages of calcium reabsorption of filtered calcium, and it's accomplished by 3 major mechanisms. Paracellular reabsorption in proximal tubule, mostly paracellular, I will say, and paracellular reabsorption in ascending lip, and the transcellular reabsorption in distal tubule. In the proximal tubule, as you can see, 1-alpha hydroxylase is upregulated in knockout. 1-alpha hydroxylase converts inactive vitamin D into active vitamin D. Upregulation of renal 1-alpha hydroxylase increases active vitamin D, enhances the expression of calcium transport proteins in the intestinal epithelium, and raises calcium absorption from gut. In ascending lip, claudin 16 and 19s are upregulated in knockout. They are paracellular channels allowing calcium to move into the interstitial fluid by the positive charge created by sodium-potassium chloride channel. And in distal convoluted tubule, calbindin D9K, calbindin 1, and cloto are upregulated. Cloto basically stabilizes TRPV5 channel, which enhances the calcium reabsorption. Calbindins bind cytosolic calcium and shuttle it toward the basolateral side, which results in transcellular calcium reabsorption. Based on the upregulation of genes, we expect that CFTR knockout may affect calcium reabsorption at 3 sites. In the aging group, there are some changes also occurring when the animals age. However, some of the changes take different directions. So there is age-dependent difference that is occurring in all knockouts. In the aging group, this time 1-alpha hydroxylase is downregulated. So there is an opposite effect in calcium absorption in the knockout aging group compared to young group. In the ascending limb, clotings are the same with the young group. In the distal tubule, among the genes upregulated in the young group, epithelial calcium channel and sodium calcium exchanger are upregulated. They work together to mediate active transcellular calcium reabsorption. Again, there are 3 major transport mechanisms of calcium. In the proximal tubule, thick ascending limb, and distal tubule. We have seen dysregulation of genes in all 3 segments. It's difficult to predict the direction of change's path. Defective expression of these components will disrupt the balance of calcium reabsorption, which may lead to some clinical outcomes, such as hypercalciuria, hypocalcemia, nephrocalcinosis, and secondary endocrine disturbances. To validate these results in the functional level, we measured urinary calcium levels in 3 age groups. Consistent with the direction of the changes based on the abnormal mineral metabolism from the transcriptomic analysis, we are seeing increasing urinary calcium in young, aging, and old group. So, absent CFTR in kidney may contribute to proximal tubule injury, altered renal transport mechanism, dysregulated calcium transport genes, and increased urinary calcium concentration. And we propose that absent renal CFTR function may contribute to abnormal mineral metabolism, bone disease, and kidney stones in people with CF. I would like to acknowledge my PI, Dr. Urban, for being a great mentor, my colleagues, our collaborators, and I'm happy to take any questions you have.
Thank you for the very interesting talk. I was very intrigued by that you saw clotho upregulated, because normally I think in all CKD models and also in aging mice, you normally see a downregulation of clotho. And I think the counterpart is FGF23. I was wondering if you looked, and this is all like, I mean, these are 2 really proteins that regulate mineral metabolism. Have you looked closer, and also have you looked at phosphate levels?
Not yet, but that's a great question. As you know, clotho doesn't have just one role. Clotho, is associated with calcium reabsorption, but also is an anti-aging protein gene, and also it is associated with hypertension, chronic kidney disease, and cardiovascular diseases. And we don't know. It's a short answer, but we haven't looked phosphate yet, but we will do it. It's one of our future directions. Thank you.
Hey, great talk. So I was wondering, so Jans Lipziger at Aarhus has this story about gavaging bicarbonate, and in the distal tubule, the secretion of the excretion bicarbonate's impaired in CF mice, essentially. So do you think ETI use might have a risk of causing kidney stones, especially in older people, as you've modeled with increased calcium?
It can be, yes.
Yeah.
Thank you.
Great, thank you.
Thank you.
The next talk is going to be presented by Alexandra Abnagonzi, who is going to talk about leaky gut, dysbiosis, inflammation, support inter-organ communication in CF.
So thank you. Thank you for this invitation that give me the opportunity to share our project that is really focused on the gut-lung axis. So I have no disclosure. So, to set the stage, I would like to start with some clinical background behind our project. If we look at gut in the timeline of CF patients, gut pathology starts even before birth with a condition known as meconium illus, and progress with several features including obstruction, mucus hyperviscosity, chronic inflammation, dysbiosis, and malignancy. So later in life, patients with CF experience infection and inflammation that leads to airway damage and chronic infection that is not possible to eradicate. It's worth noting in this slide that there are several overlapping features between gut and lung. In particular, the mucohyperviscosity, chronic inflammation, and dysbiosis are common in the two organs. So from the previous slide, a key question arises because we do not know whether the pathological events in the CF lung and gut are distinct or maybe interconnected. So we know in different other pathologies that the gut play a key role in communicating with distant organ, but this issue is not really very well explored in CF. So our hypothesis is that the gut mucosa may play a role in influencing the microbiology and immunology of the lung in people with CF. So when we target CFTR in animal model, and we have a lot of animal model, we consistently see gut pathology, so indicating that CFTR is really important in the gut. While if we look at the lung pathology, this is less evident in animal model and is only evident in larger animals as pig and sheep. One of the major problems with the mouse model is that this mouse model have been engineered in mainly in C57 black 6 mice that do not represent the genetic diversity of the human population. So if you look more closely to the CF disease, it is really evident that CFTR play a critical role, but is not the only player because the genetic modifier and the genetic background of the individual play really an important role. So to try to find a mouse model that mimic more closely CF pathology, we start to look in a new mouse population, the collaborative cross mice. These mouse populations are characterized by genetic diversity, and they have been generated by crossing 8 different mouse strains following by inbreeding. They are characterized by high allelic diversity and phenotypic variability. So we started with a screening of 39 CC line to come up with our candidate line, that is the CC037, to generate a new mouse model with the delta F508 mutation. So the screening, I do not have time to go through all the screening, but the screening has been done considering several phenotypic and genotypic traits that I will be happy to discuss at the poster. So at the end, our candidate line was CC5736. We backcross with the C57 black 6 with the delta F508 mutation to transfer the mutation in our line. We started characterization comparing with the reference line, And as you can see here, our CC5737 delta F508 has a stronger mortality compared with the inbred strain, and they have also lower body weight, so indicating that the severity of the mutation in this background is much higher. Next, we look to the lung, and we could show that at early stage, 4 weeks of age, we have early lung inflammation in HO mice compared to the wild type. This inflammation is not evident in the C57 Black 6. And not only that, because we have also systemic inflammation in the blood, characterized by higher neutrophils circulating in the blood. So when we look more closely to the lung phenotype, we can also see an increase of myeloperoxidase activity, neutrophil elastase, and a number of cytokines that are increased in HO mice of the CC background. So we also confirm this data with lung transcriptomic. This is a single nuclear RNA sequence analysis. And as you can see here, we have an increase of cytokine production, inflammatory response, but also response to bacteria, so indicating that these cells are already prone to respond to bacterial cells. We have a decrease of extracellular matrix, extracellular structure organization, and cell matrix adhesion. So when we look to the gut, we were not surprised to see gut pathology. We have gut obstruction as evident in many other animal models. We also look to the inflammatory response. I'm reporting here only the ileum, but because this is the part of the gut that is major affected, but this picture is also present in other part of the gut, and we have so inflammatory response, strong inflammatory response in the ileum. When we look to macrobiology, so in terms of bacterial cells, we have found that both in the mucosa and in the stool of HO mice, we have an increased bacterial load in the gut. So these two conditions, so inflammation and overgrowth of bacterial cells, are two conditions that may predispose to the leaky gut. So we measure the leaky gut, and we measure the integrity of the gut barrier by injecting the fitch-dextran by oral administration and measuring in the plasma. So as you can see here, the HO mice have a high fitch-dextran in the plasma, indicating that the barrier of the gut is disrupted. So next, we look also to the macrobiological profile, and we could see that in liver and lung, we have high number of enteric bacteria, so coming from the gut, and this is quite unusual because these are bacteria that should not be in this organ, but should be confined in the gut. So we also look at the metatranscriptomic data, and as you can see here, the HO mice share macrobiological component in the gut and in the lung, and this is not a condition present in a wild-type mice. So there is a complete sharing of bacteria between the two organs, indicating inter-organ communication. Next, we rescue the gut and the gut obstruction. and we used laxative Movicol in our case for 8 weeks. So we treated the mice for 8 weeks with laxative. And the result of this is shown here in terms of gut barrier breakdown. We ameliorate the gut barrier permeability, so indicating that when we rescue gut pathology, also the leaky gut is improved. And as a consequence of this, we also decrease the inflammatory response both in the lung and in the blood, so systemically, indicating that the gut permeability may be correlated with the lung and blood inflammation. So this is the summary of our key finding. I think that this mouse model was very critical to unlock the gut-lung axis. This is something that we could not appreciate in the C57 black 6 mice. And based on this animal model, we were able to show that inflammation in the lungs and blood is an early event in the pathogenesis, occurring even before mucus production. I didn't have the time to show data on mucus, but in our animal model at 4 weeks we have no mucus production, but inflammation already present. Intestinal barrier disruption is a significant event driving inter-organ communication in CF. We have a lot of bacteria that are shared between gut and lung, and this probably is enough to activate a defense response. And we point a rule for enteric bacteria before the CF traditional pathogen probably come in the lung and start a progression of the disease. And another important point is also that restoring intestinal function may alleviate pulmonary and extrapulmonary manifestation. So with this, I finish my presentation. I need to thank many people that take part of this work. First of all, Cristina Cigana in my lab, Gloria, Laura, and Davide. Many people in the gastroenterology unit, Alessandra Livraghi in UNC for mucosa analysis. I thank you for the attention, and I'm ready to take questions. Thank you.
I have a question about how do you think that the bacteria are getting from the gut to the lungs? Do you assume that the mice have reflux? Are they refluxing and then it's getting into the lungs, or do you think there's like vascular?
There are many possibilities. Because you have a leaky gut, it's possible to have a transient bacteremia. This is theoretically because, of course, in CF, it has never been detected. We have not detected bacteria in the blood, so we cannot really now declare that there is a transit. We need other studies to do that, to demonstrate that. But one possibility, as you said, is reflux, or is contact with stool. Of course, this is possible for mice, is also possible for human. Is an hypothesis that has never been considered, but because we know, I'm a microbiologist as background, so we know that Pseudomonas, for example, is taken from the environment, but what about the stool? We have a lot of CF pathogen in the stool, so it's also possible that stool is a source of contamination.
Go ahead.
Hey, a couple questions. First, I think it's really interesting that you put the Delta 508 mutation or the allele on a different background. You see a difference in severity and survival. What I'm curious is whether, first, whether or not you've looked at the inflammatory profiles of in comparison to the C57 Black 6 background.
In wild type?
No, in CF. So comparing the two CF conditions, right? The Delta 508 conditions between your new, more, I'm presuming more heterogeneous background versus.
Yeah. Are the data that I've presented. We have different inflammatory profile in the lung, in the blood, and in the gut. So the severity of pathologies in collaborative cross impact on inflammatory profile, yes.
So just to clarify, you have the same measures performed in the C57 Black 6 background?
Before the insertion of the mutation, you mean?
No. After they have the mutation, so still CF. Yes? Am I missing something? Sorry.
Yes, it is a piece of data that I've shown.
Okay.
Yes, they are different in inflammatory response.
Okay, so I'll go back.
These all these data are at a naive stage.
Okay, thank you.
Probably I missed to clarify.
The second question I have is, do you think that the microbiome is different in the different backgrounds?
We have not looked in C57 Black 6. It may be possible.
Okay.
At the moment, we are not concentrated in different microbiome, but in the sharing, and also the bacterial load is important, not only the type, but the quantity.
Thank you.
Hi, congratulations, Alessandra, very nice work. A couple of questions. One is if you have tried to transfer fecal material from the one background to another to see if you can replicate the phenotype. And the second is, all these experiments were done without any challenge, bacterial challenge or LPS challenge.
Yes.
Do you think that the outcome can be even more diverse between the two backgrounds under inflammatory stimuli?
Excellent question. So fecal transfer is in our plan. We have not done at the moment, but is in plan. There is a lot of difficulties to work with these mice because the lethality is so high that at the end we have 10% of mice surviving, and this makes all the study very complicated and very slow. Regarding the challenge, I would love to infect mice by intratracheal injection, as we do usually. It's very difficult in this animal model because of high mortality. We are now very concentrated on gut infection because I think this is a piece of work that nobody has done at the moment, and also gut infection may be very important at the early stage.
I totally agree. Congratulations.
Great model that you've developed here. I had a question for clarification in terms of your initial screening of the collaborative cross lines. Did you cross them all to CFTR, or you were screening on a wild type background?
We screen wild type.
And you were screening for what?
I screen, so if I can go back, okay. There are several, How?
Yeah, so what made you choose the CCO37?
I can summarize. There are several criteria. because the model is really very difficult. The first was susceptibility to Pseudomonas aeruginosa. So we screen for the susceptibility of Pseudomonas to have a background, wild-type background that starts from this point. High number of founder strain to assure the genetic variability, because many of these collaborative cross do not have high genetic variability, but we want one with that is very variable. Low percentage of heterozygosity to have a full inbred strain. Good breeding performance and litter size, because this is a key point. If you choose a collaborative cross line that has no good breeding performance, can you imagine after the introduction of the Delta F508 is even worse than what I described in my talk. And the absence of spontaneous disease, because many of the collaborative cross has already spontaneous disease that may be a confounder factor. So that was our criteria to come to the CC37. I have to say that at the beginning we choose two lines. One is this and the other is CC06. But by introducing the delta F in the CC06, we have never obtained CF mice, homozygote. And this is also another point, because maybe there is a lethality, embryonic lethality in some of this line, and the CFTR may be also responsible of embryonic lethality, but this is another piece of work.
And out of curiosity, did you look at pancreas at all? Did you see any?
We are looking to liver more in detail, because also, in collaboration with the Romina Fierotto, we have inflammation in the liver. I was very surprised to find enterobacteria in the liver, because they only can come from the portal vein. While we question about where they come from the lung, for liver, they can only go from gut to the portal vein to the liver. So, and this is the route of transmission. And what they do, enteric bacteria in the liver, so inflammation and many other things probably.
Okay, thank you.
Thank you very much.
So this is the end of the session, and I would like to thank and congratulate all the speakers for wonderful work, great presentations. We finished early, so there is time if you would be interested to actually ask more questions, because I know that we had to cut some questions. So we can ask the speakers to come and sit with us, or we can just do it casually if you have individual questions. It's up to you, but thank you again, and great work.